Now, the arteries of the upper extremity, it's nice to think about these as one continuous, almost like a road, right? Think about them as like a highway or a passageway, because the same structure as it travels from the major artery, which is the subclavian artery, as it travels proximal to distal, it's the same structure, but at different landmarks, it's going to take a different name. The name of the structure will change. So thinking about it in that sequential way is the best way to sort of divide it and help you remember. So the subclavian would be under the clavicle, right? Again, the names help you understand the location here. Subclavian would be the very beginning of this vessel, which is just underneath the clavicle. Axillary is after it passes the clavicle and it's passing through the axilla. The name changes to become the axillary artery. And then as it begins to run alongside the arm, the name again changes to become the brachial artery. And again, the prefix here, brachii, meaning arm. All right. So subclavian to axillary to brachial. Same structure, different points, it becomes a different name. When we get to the elbow joint, when we get to the landmark where we have the biceps tendon, as well as the median nerve. Those are some of the major landmarks that are found right crossing the elbow joint. The artery, the brachial artery, will divide into two: the radial artery traveling on the radial side, the lateral side towards the thumb, the ulnar artery traveling on the medial side, or the ulnar side towards the fifth digit. So really important to think about how it kind of, bifurcates or divides into two, and it's going to travel along corresponding side of the forearm. Okay, so in that way, it becomes really easy to follow this one vessel from subclavian to axillary to brachial at the elbow, dividing into radial and ulnar correspondingly. If we look at them with structures in place, right, in situ, the way that they are in the body, now they become a little bit more difficult to decipher when the name's changing, but the anatomy still applies. As it passes the clavicle, it becomes the axillary artery. So as it travels through the axilla, here's the axillary artery. As it runs alongside the arm, so as it begins to run deep to the biceps, along with structures like the median nerve, now it becomes the brachial artery. And then as it crosses the elbow joint, so here's the brachial artery crossing the elbow joint. Other structures we have here are going to be the biceps tendon, the median nerve crossing. And in the middle of those two structures, it divides to give us the ulnar going medial and the radial going lateral. Okay, and then the anatomy will continue in the forearm, radial traveling along the radial bone towards the thumb, ulnar traveling along the ulnar side towards the hypothenar surface of the hand. Okay, so pretty straightforward if you think about those principles. But definitely when you look at an image, first thing, orient yourself. Am I looking at right or left? Because that will determine if I'm seeing the lateral side of the forearm or the medial side, which will determine, am I looking at the radial or the ulnar artery? So looking at this view, I want to immediately identify, this is the hypothenar surface of the hand, this is the thenar, this must be medial, this must be lateral. So this is my radial, and then the ulnar. Let's look at veins. Veins have a similar principle, but veins are going to be a little bit more superficial, and they're going to sort of drain or converge into themselves as opposed to branching the way the arteries do. So the basilic vein on the medial surface of the arm, basilic vein is going to collect drainage from the medial cubital vein. And then we have the cephalic vein on the lateral surface of the arm. So both of these are draining towards the axillary vein. The axillary vein is going to be the corresponding deeper vein that drains back to the subclavian vein. So we're now looking at flow in the opposite direction, converging towards the major veins. Cephalic is also going to run between some of the muscles we described earlier, such as the deltoid, pec major, and the proximal aspect of the humerus and the upper limb. So the cephalic is going to be a little bit more superficial, actually running between the heads of those muscles, whereas basilic is going to be on the deeper aspect of the arm and also on the medial side of the arm. Then we have the median cubital vein. This is actually the vein that you get venipuncture when you collect blood for your lab tests, etc. That is going to be collected at that site, the median cubital fossa, via the median cubital vein. And it's going to be between the basilic and cephalic, which is really kind of a connecting point of those two veins, right? It's kind of connecting flow that's going to those two veins. Next, we have some of the nerves as they traverse, right? It's important to think about the brachial plexus. And the brachial plexus is the network of nerves that come from the cervical vertebra. So we talked about the cervical vertebral column, where we have the cervical spinal nerves that are exiting at each level. And they come together, specifically the C5 to T1 spinal nerves, come together, kind of bundle themselves up to make this plexus or network, and then they send out 5 terminal branches. So we call that plexus the brachial plexus, and we're going to look at the terminal branches here, which is what's more important for our purposes in this class. So the first terminal branch, well, actually, before we talk about the branches, let's talk about how this network appears. So it actually appears to give this M-like configuration. All right. This M-like is going to be very helpful when you're trying to figure out which nerve is which, okay? Because you'll always be able to find this M, based upon looking at different images. So when you look at the M, the lateral side of the M is going to be the musculocutaneous. The middle of the M is actually going to be both parts helping to merge together to form the median in the middle. And then the medial side of the M is going to be the ulnar. So lateral side of the M, musculocutaneous, middle of the M, median, medial side of the M, ulnar. Okay, lateral, middle, and medial. Now that will help you understand that as soon as you find the M and you find lateral versus medial, automatically you can identify those first 3 nerves: the ulnar nerve, the median nerve, and the musculocutaneous. Now the other 2 are going to be deep, so it's going to be very hard to see the other 2 from the perspective of an anterior view or from the perspective of the M here. The other 2 are coming from the posterior cord, which is a different part of the brachial plexus, and they actually go behind the axillary artery. And if you look at the middle structure here, this is actually the axillary artery, which is what helps to divide the M, but also helps to divide the anterior structures from the posterior structure. So the artery, the axillary artery, is sort of a landmark that helps to give these nerves their name. Now the posterior cord is going to have the other 2 branches, the radial nerve, which really supplies the back of the arm, which is why it's on the posterior side, and the axillary nerve, which goes and supplies the shoulder. So you can see it kind of curving off here right away. It's going to go to supply muscles like the deltoid, which are closer to the shoulder. All right. So that will help you understand where these nerves are and how to find them based upon that view once you find the M configuration. Now, looking at them functionally, the ulnar nerve supplies the medial muscles on the forearm and hand. Ulnar nerve supplies nothing in the arm, okay? Only the forearm and hand on the medial side. Median nerve supplies anterior compartment muscles, but on the lateral side. Okay, again, nothing in the arm. Musculocutaneous, on the other end, supplies the arm muscles only. So it supplies those 3 arm muscles that we talked about: brachiobrachialis, brachialis, and biceps brachii, all supplied by the musculocutaneous. In fact, we talked about the musculocutaneous as actually piercing the coracobrachialis muscle, which is another way to associate those 2 muscles together, or those 2 structures together. Then we have radial nerve on the back supplying all of our posterior muscles. So all of triceps, all of the extensors on the posterior compartment of the forearm. And then axillary nerve supplying shoulder muscles, deltoid and teres minor, two muscles only, okay? So that will help us to think about where they are. Radial is gonna go right down the back of the arm because it supplies everything from the shoulder onward. Axillary is gonna take a turn right away because it only supplies the top, it only supplies shoulder muscles. And then median nerve goes right down the middle, passing the arm, does nothing in the arm, supplies the lateral side of the forearm. Ulnar nerve traveling on the medial side, again, supplies nothing in the arm, supplies medial side of the forearm, and then musculocutaneous only supplying muscles in the arm. All right. So just some interesting connections there to help you remember those. So here's what I mean by finding that M configuration. And we can see that M here very clearly. Here's the lateral side of that M. There's the middle side of that M. Here's the medial side of that M. So that makes this the musculocutaneous. And we can see it actually piercing coracobrachialis. Here's coracobrachialis. Here's biceps brachii. Here's the cut surface of the pectoralis. Here's the rest of pec. Then we have the middle of that M, median, going all the way down to the forearm. And then we have the lateral side of that M, ulnar, going all the way down to the forearm. Okay. Now, if we peel back the anterior structures, so notice how the M wraps around the axillary artery. And in order to see the posterior cord structures, we have to kind of peel it back. So if we peel back those anterior structures, now we can see the axillary artery, and now we can see the posterior cord and its two branches, which are the axillary, turning immediately to supply shoulder muscles. All right, here's the axillary. And then the radial going all the way down the back of the arm to supply all of the extensors of the arm and forearm. Okay, so always think about the view. Can I see the M? If I can see the M, I can find the first three. If I have a more retracted view where I can't see the M, I can better appreciate the posterior two branches. Okay, that's how you can find those 5 branches. Let's wrap up by looking at the joints and ligaments. So the joints that help to secure the upper extremity, we sort of introduced these when we talk about the appendicular skeleton. First off, the pectoral girdle. And the pectoral girdle has 3 joints. It has a sternoclavicular joint articulating the sternum to the clavicle. It has an acromioclavicular joint articulating the acromion of the scapula to the clavicle. And then it has a glenohumeral joint, which is where the head of the humerus articulates into the glenoid cavity, forming the ball and socket shoulder joint. Now, all 3 of these will typically move. They have different ranges of movements, and they're different types of joints, right? The sternoclavicular is more of a gliding joint. Shoulder joint is more of a ball and socket joint. So they have different properties, different ranges of motion, different categories of movement, but they all move to give various shoulder actions. Next, we have the, okay, so here's the sternoclavicular joint. And there's more complexity to the joint. There are smaller ligaments that help to articulate it beyond the scope of this class. All we need to know, sternal end of the clavicle articulates with the manubrium of the sternum, specifically at the clavicular notch, one of the landmarks that we discussed earlier. It's also going to be helping to form a joint slightly with the first costal cartilage. So the first costal cartilage of rib 1 is also sort of anchored to adhere that joint. And this is actually one of the strongest joints in the body. It's a very secure joint, which is why clavicular fractures are so common. Instead of fracturing or dislocating this joint, it's easier to just fracture the clavicle, right? That's how tough, how secure, how strong this joint is. Let's look at the acromioclavicular joint. This is between the acromion of the scapula, again, that's top point, highest most landmark of the scapula, and the acromial end of the clavicle. So this is what creates the upper shoulder joint. You can actually palpate this on yourself pretty easily. And there are several ligaments that actually secure these joints in place. The acromioclavicular ligament between the acromion and the clavicle, as well as a smaller coracoclavicular ligament, which is actually between the coracoid process and the clavicle. So the coracoclavicular just helps to anchor the clavicle and the coracoid, which just further secures that acromioclavicular joint. So that is to say that the coracoid process is not articulating with the clavicle, but they are being anchored together by this really strong ligament. Next, we have the ball and socket joint or the synovial joint. This is the glenohumeral joint. So this has much more movement and much more range than the other two joints that we looked at. The other two joints are actually fibrous joints. They're more suited for structure and integrity, whereas this is much more suited for movement. It's going to have the deep cavity, which is the glenoid, and then it's going to have the head of the humerus, which articulates, and the anchoring, right? A lot of the structural integrity of that joint is not only through the ligaments, but through the rotator cuff muscles, which we described earlier, that help to secure that head into the glenoid. As well as the glenohumeral ligament. So the glenohumeral ligament has several different parts, but they anchor, again, the head into the glenoid cavity. And then the coracoacromial ligament, which is between the coracoid process and the acromion. Again, that is very different from the other two that we described, the acromioclavicular and the coracoclavicular. So acromioclavicular, coracoclavicular help to anchor the acromioclavicular joint, whereas the coracoacromial and the glenohumeral help to anchor the glenohumeral ligament or joint. Let's move down to the elbow. Now, the elbow is a hinge joint. So again, a different category of joint altogether. It only has movement in the sagittal plane. So it only has, the frontal plane. It only has movement of flexion extension in the frontal plane. It's going to be articulated by the trochlea of the humerus, articulating with the trochlear notch of the ulna, as well as the capitulum of the humerus articulating with the head of the radius. And we kind of talked about those articulations and the flexion extension movements before. Now, the ligaments that reinforce that joints, there are three of them. Lateral reinforcement from the radial collateral ligament. So here is a medial view, here is a lateral view, and the radial collateral or lateral collateral ligament helps to anchor the radius to the humerus. Okay, and it can be seen more from a radial or a lateral view. On a medial view, we can appreciate the ulnar collateral from the humerus to the ulna. Okay, and that again helps to secure the head of the ulnar or the trochlea of the humerus with the trochlear notch of the ulnar. And then the head of the radius is secured by the annular ligament. This is what prevents the head of the radius from just popping out. Okay, in fact, when parents swing their children by their arm, which is very common, really small toddler or child, and parents are swinging them one on each side, this is the injury that we see where the radius pops out of the annular ligament. So that is what actually helps to keep the radius secure. But in really small children, where these ligaments aren't as well, developed and secured, that can pop right out and can be easily popped right back in. So that is the three ligaments that help to secure the elbow joint. Lastly, some of the joints at the hands. These articulate some of the phalanges, the carpals and metacarpals. First, we have the metacarpophalangeal joint between the metacarpals and the phalanges. This is between the ends of the metacarpals and the heads of the proximal phalanx. Then we have the proximal interphalangeal joints between the ends of the proximal phalanx and the heads of the middle phalanx. For the first digit, it's the end of the proximal phalanx, but remember, there is no middle phalanx in the first digit. So there really is no proximal interphalangeal joint. There's a metacarpophalangeal and then an interphalangeal. And then the distal interphalangeal joint, the very distal tips are going to be between the middle phalanges and the distal phalange and creating the DIP or distal interphalangeal joint.